Most of the time, good supportive care in cancer is advocating and enacting change for one person at a time. But sometimes it is doing so for half of the world population. Meet someone who's doing just that. I'm Bogda Koczwara, and this is Supportive Care Matters. My guest today is Dr. Ophira Ginsburg. Dr. Ginsburg is a Canadian medical oncologist and global women's health researcher with nearly 20 years of experience in global cancer prevention and control. She's a senior advisor for clinical research at the National Cancer Institute's Center for Global Health, and her previous roles included work for the WHO, World Health Organization, where she provided technical support on cancer control for countries in Africa, Asia, the Middle East, and Latin America. Her recent work as a co-chair of the Lancet Commission on Women, Power and Cancer has just been published earlier this year in the Lancet. Ophira, welcome to the show.
Thank you so much for having me.
I am truly excited to speak to you this time because your story conveys how supportive care in cancer can really have a very, very broad reach. So we're venturing beyond the concept of looking just at one patient, but really looking at the populations at large. But perhaps the listeners may need a little bit of an orientation in the work that you do. You are a global health researcher. Can you explain to us of what global health is and why it is important?
It's such a good question. In fact, it's a question that many of us are asking ourselves now in light of long overdue disparities in power, actually. The asymmetries of power, such as what we bring out in our Lancet Commission, also are inclusive of global health powers. So I would say I like the Wikipedia definition, which is that global health is about achieving better health outcomes for vulnerable populations and communities, or for all populations throughout the world, period. Historically, the concept of global health came from international health, which has a lot of a fraught history, which we don't have, I don't think we'll get into today. Why is global health important is because it really is about all of us, right? I work in the U.S. now at the U.S. National Cancer Institute Center for Global Health, and we've been discussing this very intensely in the past number of months when we talk about so-called domestic or local cancer health disparities as being somehow a distinct field of research, study, practice, policy, versus what's global. And what we have to remember that Canada, the US, UK, Australia is part of a global community. And so it's important for us to come back to sort of a reality check and consider that health has no boundaries. It isn't just about global health security with infectious disease risks, which people often think of when they think of global health. They think of Ebola. They think, of course, more recently of the COVID-19 pandemic. But in fact, even when it comes to the non-communicable diseases, what happens in Pakistan and Mexico and Bulgaria is relevant for all of us, particularly when it comes to cancer's impact on the global economy.
So in your work, you're bringing together issues specifically focused on women. Why women as a priority in global health?
Women's health traditionally has been focused on sexual and reproductive health and maternal health, which is incredibly important. And I would never want to take away from the tremendous gains made in the last, especially 20 years, starting, I guess, with the Millennium Development Goals that some listeners may be aware of, that pushed us all, that pushed countries to consider a better future for women and for children. And that is all very, fine, except when we don't consider that most women nowadays in all countries are more likely to die prematurely, and by the way, of preventable causes and treatable causes like cardiovascular disease and cancer, of the non-communicable diseases, than they are of these historically thought of as women's health conditions. And the impact when a woman is lost to her family, it has tremendous impacts to the family, community, and society and economies, far beyond what we consider as an individual, of course, tragedy for that particular family.
So in a way, what you're doing is you're looking at women's health as a in a way, a litmus test to societal health at large, because it impacts on other members of society, both at families and societal level, and the economic and the sort of broader impact on health at large, isn't it?
Yeah, I like the way you put that. And I would add that I know we're going to speak about the Lancet Commission on Women, Power, and Cancer, but just to give you a bit of a setup to that, we have been very lucky to work with one of our colleagues at the WHO's Cancer Agency, where I was a senior visiting scientist prior to coming on to the National Cancer Institute. Dr. Valerie McCormack works at IARC. That's the International Agency for Research on Cancer in Lyon. Your listeners should be aware. She and her colleagues, including some of us, put together the first ever global estimates of children who become maternally orphaned when the mother dies of cancer. And it shocked us. We knew it was a problem. We asked that question in a Lancet series, Health, Equity, and Women's Cancers, that I helped to lead some years ago. But we didn't have any numbers attached. So for your listeners, just in 2020 alone, right, globally, 1 million kids lost their moms due to cancer. And when we looked at the prevalence of maternal orphans in that year, so kids who had lost their moms at some point and were still considered children under the age of 18, the UNICEF definition of orphans. In 2020, there were more than 7.5 million kids who'd lost their moms. So what does that mean for those children? In many settings, it almost assures that they will remain impoverished, almost assures that they will not be able to seek higher education, and on the impacts to the family and the cycle of poverty. And most of the women who died leaving behind those orphans actually were in the so-called global south. They were in countries that are considered low income and lower middle income and upper middle income, particularly in Africa and Asia.
Astonishing figures, aren't they? Also, really emphasis on how important is the data and how important is the ability to connect all those different factors that kind of put the illness in context of the broader societal dimensions. And it seems that that's what the Commission has done. So what is a commission? Can you explain to me what sort of what the Commission might be, how it's set up, and what it aims to achieve?
Well, broadly speaking, a commission is really an ask of people to try to tackle a big problem. And in the case of the Lancet commissions, and there's also the Lancet Oncology commissions, we were asked by the editor-in-chief to consider taking forward what we had done. I mentioned the Lancet series, a 3-part series called Health, Equity, and Women's Cancers that was published 2016 online, and see where we were at some years later with respect to women's cancers. So initially, I thought, well, is that really enough? Are we just going to take stock of where we're at with respect to breast cancer and cervical cancer, which were 2 sort of exemplar cancers that we looked at through the lens of equity? Or should we really broaden it? And first of all, just to get back to your question of what a commission is, it's really a group of people. I was very fortunate to be asked by the Lancet to put a commission together. And so the first thing one does is consider, what do we want to tackle? In broad strokes, not to be prescriptive, because everyone on the commission eventually who was invited and agreed to spend so much of their personal time and effort and energy on the project should have an equal say. We really became a collective. But in the first instance, I fleshed out a concept note of what we called back then women and cancer, which I based on the great work of Professor Anna Langer at Harvard University and her previous commission in the Lancet called Women and Health, which was the first one to take a look holistically of the role of women, the intersection or nexus of women regarding health, whether they're providers of care, recipients of care, those seeking care. So that was sort of the inception. And we published, myself and Richard Horton, July 2020, this sort of announcement describing we have a commission. And then I went about inviting co-chairs and a group of commissioners, and we eventually became a collective. We consider ourselves actually a feminist collective, which includes the way we govern ourselves, how we make decisions collectively. And we published that on our website very early on. So more than 2 years ago, you could read our guiding principles. Some people thought that was a lot of, hoopla and maybe unnecessary, but in retrospect, I think we were really right, given the attention now that the report has come out that we've gotten globally looking at, what is a feminist cancer commission? Yeah.
The very first feminist cancer commission. But you started from women and cancer, and then somewhere along the way, there was power
Mhm.
in the middle of it. How did that happen?
Well, I would say power was always there, but we didn't recognize it, right? Isn't it like that, right?
Oh, and you didn't name it. Yeah.
We didn't name it. The name eventually came about partly because a commentary was written by former president of Chile, Michelle Bachelet, one of my heroes, Shiros, who then, after she wrote a commentary for the Lancet series I mentioned, and she called that commentary Women, Power, and the Cancer Divide. Wow, right? And then she went on to become the UN Human Rights Commissioner. So we went back to that original piece that she had written and really started considering what was at the heart of this topic. What is impeding? I mean, I'll go back a moment and say, for my own professional/personal journey, it was when I was working in rural Bangladesh a lot more than 10 years ago, when I realized women coming to the clinic I co-founded there for breast health, for breast cancer, were so impoverished. They had so little opportunity to make choices that we would consider the right choice. Right? And they told us why they hadn't come until now when we asked them, with a fungating breast, very advanced, locally advanced breast cancer, what took you so long? Ridiculous question, right? Why did you wait? And they told us about the fact that they didn't feel they had a choice because of the poverty, because they may not be the locus of decision-making in their family. That is up to the men or the in-laws, the mothers-in-law, etc. And so that concept of power was always floating around in my own head, and certainly in the minds and hearts of the many commissioners we have from different countries, different academic disciplines, men included, tremendous allies in the men on the commission. And we decided that power was really at the center here. So eventually we put it in the title.
So I remember as a medical student and subsequently as a young oncology trainee, I was quite influenced by a book by an ethicist in the United States called The Healer's Power by Howard Brody. And he talked about the importance of power in healthcare, but he talked about it from the perspective of one healthcare provider, one clinician, and one patient. Whereas you and your colleagues took the concept of power in a much, much broader sense in terms of the power dynamics in society and how it relates to healthcare. And of course, what transpired from it is that the findings of your commission are broader than just people as recipients of healthcare or people as sufferers of particular illness, because in the commission report, you touch on the issues of power of women healthcare providers. So this is actually incredibly novel approach. Were you surprised by your findings?
Well, we were to some degree. I think we were surprised by how deep and deeply entrenched these asymmetries of power are everywhere in all of our countries to one degree or another, sometimes surprised by the fact that gender parity, for example, with authorship, first and last authors, many academics, I'm sure, are listening to this, that matters. That's a currency of a sort when it comes to professional development in oncology and other health disciplines, that some of the countries that were doing better in terms of female/male authors were in so-called low and middle income countries, and Western Europe and North America did particularly poorly. So we were, pleasantly surprised, also humbled by a lot of the findings when it comes to women in leadership positions in so-called global oncology in the cancer domain. Aortic, the African Organization for Research and Training in Cancer, is largely led by women and has been for some time. So, we have a lot to share and learn from and to make sure we overcome the tendency to make quick assumptions, those knee-jerk assumptions that we, in the Western countries,
Yes,
are somehow better at this or that, right? My goodness, it's humbling.
That is such an important point, because we tend to think, first of all, of global health as something that happens somewhere else in tropical countries that we visit for vacation, as opposed to in places where we normally work. And the second thing is tends to be an assumption that it is the wealthy, well-resourced settings that have all the answers. And yet, if you go to countries with more limited resources, there is incredible ingenuity, and a lot of it comes from women. And that's not just in healthcare, in economics innovation as well. So in a way, you're kind of putting the concept of global health on its head. And that's actually incredibly exciting.
Yeah, we think so. And, trying to put it all together in a concept, in a framework, that was the big challenge. But again, that's why it's important to have so many great people come together to try to solve a challenging problem, which is really the point of a commission. So myself, I'm kind of a quantitative person. I trained pretty traditionally in academic medical oncology and also in clinical cancer genetics, epidemiology. And we had some real powerhouses in social sciences from all around the world. We also had a medical anthropologist who focuses on poverty and cancer, bring together a feminist scholar to try to come up with an overarching concept, really. And we encourage people to look at that diagram, that framework. It's a mock-up in a way. There's a lot that could be done with it. It could be adapted and reshaped. But having, women in all their diversities at the center and showing the ways in which power asymmetries in 3 domains, that's in terms of knowledge, decision-making, and economics, influence the way in which women interact with cancer in terms of the health system, biases, gender bias impacting whether they're going to come for care. More women than men are likely to present with an emergency presentation of cancers that are not sex-specific. I didn't know that, broadly speaking. You always think of women being more proactive about their health, more likely perhaps to get colorectal screening than men because they're also very active in breast screening or cervical screening in this or that setting. But it turns out it's actually not the case. You need to look at the data. So just to wrap up with the framework, there's the framework, and then there's the overarching single recommendation that gender and sex, and we are clear about the differences, are considered in all aspects of cancer research, practice, and policymaking.
So in contrast to history, where you think about women's health as reproductive health and breast cancer and gynecological malignancies, it's kind of across all layers. And that's, again, a more innovative way of looking at an issue.
That's right. And some people have asked, we're often asked, why not men? Men often ask that. Don't men have a higher risk of cancer than women? And the truth is, yes, they do, but not by much. And that's kind of beside the point. A lot of what we're discussing is power within families and communities, right? And women's health, women's cancer-related outcomes, including their opportunities to seek and obtain high-quality supportive care. We only touched on this. We couldn't do everything justice for sure. But those things can be influenced by where a woman lives. So a woman who has resources living in New York City, where I'm based, may have a much easier time having a discussion, feeling comfortable, having a provider raise the question of sexual health regarding their cancer treatment. Whereas a woman in, rural Uganda may not have that opportunity. So again, this is just to emphasize that this wasn't also women versus men, but to look at things from a more holistic perspective and dig into the data where it exists. The health systems analysis we did was all cancers, all countries, women in different situations and settings, including those who identify as belonging to diverse sexual orientation, gender identity, or expression, was really telling. And that also came out in the stories we told. We have 9 first-person accounts, 9 stories of women in different settings, including 2 health workers. So, yeah, I think I'm very proud of that, the fact that we brought out much more than just showing the quantitative data, which is really, it's fine. That could have been 1 or 2 academic papers in their own right. But we're hoping what we have rendered is greater than some of its parts and really will be thought-provoking for action. Yeah.
Yes, it's the data that informs you, but it's the story that moves you, doesn't it?
Oh, exactly. Well put. Yes.
So we will be putting the link to the paper in the podcast notes so the readers can actually go and have a look at it in detail. And I must say, I've been incredibly impressed by how relatively concise piece of work had managed to capture the complexity of the issues. Because in a way, such rich and diverse range of issues runs the risk of being confusing, whereas the way the information is presented is incredibly clear and systematic and structured in terms of identifying not just what are the issues in a kind of linear one by one way, but of how they are related, how health relates to power, how patients and healthcare providers might interact, how things change according to geography, socioeconomic setting, etc. One particular area that I'm very interested in is how you managed to put together cancer and cardiovascular disease as two common conditions that affect people all around the world and how they interact. Historically, these two are often seen as sort of almost competing priorities, whereas you managed to sort of highlight that they often coexist and there's a need to sort of to look at them together. And I think that there was just so many other examples where you managed to unpack the complexity in an incredibly approachable way for somebody who may not be familiar with the topic.
Thank you very much for that. That was the single biggest challenge we had, was to come up with something that was, readable, understandable, and to not get so far into the weeds in one particular area that it would somehow feel imbalanced as well, which is really a hard thing to do. At the same time, to offer an opportunity for the reader to consider cancer is just one group of diseases which we are focused on, but could be seen as an exemplar, or at least an example, of other common health conditions which have either been ignored or underappreciated in women, or considered only from the perspective of the white 70-kilogram man, for those of you who've gone to medical school, right? So cardiovascular disease being incredibly important. That work came from pre-existing work done by Freddie Bray and Isabel Sorio-Mataram, who are on our commission. Isabel's one of our co-chairs. That they had done that and produced those maps for cardiovascular disease and cancer, but they didn't report sex disaggregated data. So our own colleagues, came to the commission and we said, that shows us something. It was hiding in plain sight. We didn't think to do that. So we looked at the data again, and in the report, you'll see the data for females where cancer or cardiovascular disease are among the top 3 causes of premature mortality in all but 2 countries out of 185 countries. It was right there. It was right there, and we didn't see it.
You haven't given yourself enough credit for an incredible achievement that not only did you unpack the issues, but you actually managed to venture into the territory of proposing some solutions. It's very easy for issues to be presented as a long list of problems without any suggestions of solutions, whereas you have very structured recommendations of what to do. Can you speak to those a little bit and perhaps highlight what do you see as the easiest, and what do you see as the most challenging next steps to address the issues that you've identified?
Right. Well, I think in a way, the easiest is just to look at the data that already exists. And so in every domain, like I mentioned as an overarching recommendation, that gender and sex must be considered, not just considered, but collected, reported. The data needs to be brought to light. And in many cases, it's right there, hiding in plain sight. So that, in a way, is a low-hanging fruit. Right? We already have women and men, or females and males, in cancer registry data, for example. Whether we actively make a point of reporting and looking at differences, which we do between countries of different human development index and all of that, but we often don't look at the sex differences, particularly with non-sex specific cancers. So that's one. Then there's some small low-hanging fruit. For example, I'm just thinking what was one of the ones we really thought would be easy would be to look at, well, it's not easy, but it's something that we need to do, is to enforce fair pay standards. Okay, that's not easy. That's something all countries struggle with.
Should it be easy?
It should be easy. It should be obvious that we have pay gaps. And how is this still happening? Or having a zero tolerance policy for gender-based bias, but gender-based harassment in the workplace. I can't believe we're still having that conversation, but we need to have it. As I think I said during our launch event, cancer needs to have its Me Too moment, right? And so those are things that should be lower hanging fruit. The harder ones would be, for example, to develop and validate a feminist economics that could be applicable to different aspects of cancer. Our economics working group did a phenomenal job of proposing and presenting a few proof of concepts, such as what a gendered investment case for cancer would look like. So how are things different in the case we took of colorectal cancer in Peru? What do we know about cancer prevention, early detection, and treatment and outcomes, right, for colorectal cancer in a setting where there was already some data to suggest whether women would prefer to have this or that kind of screening? We know the biology is different, that women are more likely to have right-sided tumors. So, if you were looking at investing in FIT immunohistochemistry or Cologuard or what have you versus nurse-led sigmoidoscopy, which hasn't really taken off in many places, but perhaps should. But if you are a woman and you're more likely to have a right-sided tumor, a flex sig in the office for those clinicians in there is not, you're going to miss a lot of cancers.
Yeah, exactly.
Kind of went into the weeds there on that one example, but that's a bit more challenging. And then the really probably in some ways one of the more important recommendations that we want to emphasize that is definitely easier said than done is to, co-create accessible and gender responsive and intersectionally reflective responsive health systems to provide respectful quality care for women. And I might add, coming back to that women versus men argument some men have asked us, some women too, is that if we could achieve even some of these recommendations, if we could take actions, and we're going to be tracking and monitoring, I'll talk about that in a minute if we have time, we would help improve opportunities for cancer prevention, early detection, care, and better survivorship and quality of care for persons of all genders.
Absolutely. So how can we track it?
Right. So right now we have a group working on developing a key set of metrics, what we might call key performance indicators, which allow us to see what data already exists that we could track over time. And if there isn't such a metric, could we come up with one? It's not just for us to do as the commission, it's for us to help others to think through and work with us, who they're aimed at for readers who want to take a look at the executive summary and the table towards the end of the report, where we even give a few examples of who, what, when, how, and the why is the whole commission report. So for example, tobacco control for preventable risks that we already know of. We also have emerging risks that we need to understand better. But for the risks we know, the four major risk factors for cancer, tobacco, alcohol, overweight, obesity, and infections, we quantified that 1.3 million women's lives would be saved if just those four risk factors were taken care of. So what do we know about gender-specific policies within tobacco control? Well, they exist. We summarized those in the report. There's already some tracking mechanisms there. And others need to be better elaborated, let's say. The Roots framework for obesity. There's some interesting work by Johanna Ralston and the World Obesity Federation looking at gender aspects of overweight and obesity, including countering stigma, but also helping to orient people towards and policies around better nutrition in every setting, whether it's food deserts, the rest of that story. So there's a lot of policy work as well that needs to be done. That's not really our job as the commission to do it all, but to help propose it and put it out there for other people whose areas of expertise are those areas to take forward.
You've touched on the topic of policy, and clearly a lot of recommendations and a lot of way forward in this work sits in the policy space, which is important, but it's not exactly what I would consider a mainstream on conventional, let's say, oncology. How do we make it into the mainstream? When I go to the conventional cancer conferences, the policy geeks sit in small rooms at the periphery of the convention center. How do we bring it forth into a broader discussion beyond the raising the issues as you did with your work?
Mm-hmm. Well, I'm hoping that this podcast actually, and I commend you for having this series. It's a superb podcast. More conversations are happening like this now, and gatherings of oncologists, of cancer epidemiologists, of other researchers are starting to realize that we can't impact things upstream by ourselves, especially if you're trained as a clinician. You don't always have the opportunity to learn what brought this patient here today at this time with this condition and their set of circumstances that led them to come perhaps later than they would have liked to come with their diagnosis, for example. Those are policy drivers that influence where we are sitting at as clinicians in the office with a patient. I'm going to take an example of something else happening that I think is exciting. It relates to what we're doing, relates very much to supportive care and outcomes that matter, is the common sense and oncology movement. And for readers who may not know about this, this is really just a coalition of the willing, like many of these things are, bringing together from colleagues who happen to be at my alma mater, Queen's University in Canada, Dr. Chris Booth and Dr. Vishal Gyawali, and others, Dr. Manju Sangar from Tata Memorial in Mumbai, and a global group trying to put together a case for bringing common sense and community and compassion back into the practice of oncology. That will take influencing policy. And not everyone wants to do that, has the skills to do it, or has the time to do that. So we need to work with people who are interested in cancer policy. There's an Institute of Cancer Policy here where I'm sitting right now in London at King's College London, led by Professor Richard Sullivan, who is world renowned for his work in also health systems, cancer economics, et cetera. But more people are starting to have these conversations. And it's not so much that we're sitting in little rooms and making decisions, but we're finding that we're starting to be invited, or maybe being a little bit pushy and getting ourselves into the rooms where people are making decisions, including what's going to be in the plenary sessions at next year's fill in blank, ESMO, ASCO, et cetera, AACR, the big cancer meetings, the societies that normally focus mostly on phase 3 clinical trials, they're starting to take a real interest in what drives us to be in this position now, having to discuss a 2-month survival advantage at $20,000 a month with our patients.
Yes, so this is this old saying, culture eats strategy for lunch. And I think it's the cultural change that is moving things along and puts these issues at the forefront. So perhaps if I could just sort of sidestep and turn into a slightly more personal question. As a fellow medical oncologist, I don't remember being trained in policy issues or global health for that matter. How did you arrive at that point? Sort of, I would imagine that when you trained, there was no common sense oncology as a program. And yet you've managed to venture into such an important and innovative area. What was the journey?
Well, the short version is that I was working in, I guess, what we'd now call social justice and human rights work on the side since I was a teenager. And I first spoke about children's rights at the age of 12 for a radio show. So I've been doing that part a long time. And I never really connected the dots because I never heard about global health. I knew that there were people helping with child poverty, and I knew certainly about infectious diseases that could transcend borders. But like many other people, I just didn't see the connection until I was well into my training, already into my medical oncology training. And I kind of saw the world coming in front of me, that treadmill you see, giving chemotherapy and being an academic oncologist in Canada. And I felt like there would be something missing if I didn't take a moment to take a look and see how else I could use my skills and combine that passion I had for social justice with a career in oncology. And I took a backpack. They very nicely at the University of Toronto let me off the hook for a couple of months. And I traveled solo, backpacked through rural areas in Southeast Asia and went to hospitals and talked to people in villages. And it seems a bit crazy now because, of course, there were people doing more structured work in what we now call global oncology, but I simply didn't know anyone doing that kind of work. And people thought I was nuts. So I did it, and it started me off on a journey to find people who were like-minded, who were doing interesting projects. I came at it from a research perspective because that's kind of what I knew, and clinical practice. So co-founding that clinic in rural Bangladesh and then seeing, wait a minute, these women, why are they coming in like this? How can we help them better? I started looking further upstream, and eventually the 30,000-foot view took me to the World Health Organization. So far up that I couldn't see the ground, a bit too far. But for 1 year, I was a medical officer in Geneva at the WHO, which was a tremendous privilege, gave me a chance to learn very quickly that I didn't know anything. It was really humbling to realize the degree of ignorance I had about health policy, about global health. And I wouldn't recommend people doing what I did, obviously. You should go and get some formal training in this area. But they needed somebody quickly to come and help inform some of the guidance around early detection for cancer, breast and cervical cancer, et cetera. But that's where I really started seeing things from that new lens and trying to see how it would align with my overall objectives. But I'm going to be speaking about this Friday, actually, at the Royal Society of Medicine about navigating a career in global oncology as part of the London Global Cancer Week.
But for those of us who might be on the other side of the globe, I hope we're not going to upstage the Royal Society if we ask you, what would be your one tip for somebody who is at the cusp of their professional career and would want to get into the area of global health today? What would be your word of advice?
Right. I guess first, it depends where they're at in their career. So I do a lot of one-to-one discussions with people who are undergrad medical students or people who are nearing retirement as oncologists, for that matter. I always suggest attending meetings like the World Cancer Congress and like the Aortic African Organization I mentioned meeting we just had in Senegal a week ago, and listening, really listening, being present and assuming that you know nothing, coming in with the best of intentions and learning. And in some cases, depending on where people are at in their career, they probably should pursue some formal training in global public health to get a better grounding and understand what's already been done before, successes, challenges, et cetera, understanding the policy sphere and finding out what makes them tick, what would align with your own, what gets you up in the morning. And I usually end with an image of ikigai, the Japanese concept of finding meaning in everyday life, to get people to focus in on that for themselves.
Sounds to me that there's a lot of interesting things that get you up in the morning. So can I ask, what sustains you and inspires you in this work?
People, the people, the patients I've had the privilege to meet and be part of their care over the years, the colleagues I've had, my mentees who continue to amaze and surprise me and humble me, and having that sense of the community. It's going to sound very maybe naive and pie in the sky, but I really believe that there is such a thing as a global community. And if I didn't believe that change was possible in social justice, in climate and everything else, I wouldn't get up at all.
In my part of the world, in New Zealand, there's this saying, a Maori saying, which goes something like this: what's the most important thing in the world? And the answer is, it's the people, it's the people, it's the people. And I think that kind of captures everything, doesn't it?
Yeah.
Well, Ophira, you've been such an amazing person. Listening to your story, I am inspired. I think I have every motivation to get up in the morning and maybe perhaps even change my career. You've really showed us that supportive care is just such a rich concept. And there is just so much that we can do, and so much that one can do not just for one person, but for millions or perhaps billions. So to finish off, as is the tradition of the podcast, one question for you, your top reason why supportive care matters.
Because people matter. Supportive care is at the heart of what we do in clinical oncology. Without it, I'm not sure what the purpose is of giving a treatment or having a single conversation with a patient and not taking into account the whole person and their family and community, what that means for them to get through the day, whether they want to return to work, what are their goals, to achieve, whether it's attending their child's, high school graduation, et cetera, the nature of their relationship with their friends, families, romantic partners, et cetera. It's really so much at the heart of what matters and what should matter in oncology.
I truly have nothing else to add. Thank you so much for joining me today. I really appreciate it.
Thanks so much, Bogda. It's been a pleasure.
That is all for Supportive Care Matters, a podcast created by me, Bogda Koczwara, for researchers, clinicians, policymakers, and patients passionate about improving the lives of people affected by cancer. Thanks to Mark Tai, who composed the original music, and the Oncology Network, our producers. For show notes, go to www.oncologynews.com.au. Subscribe to this podcast at your favorite podcast provider and rate us. It will help others find us.